You're a pediatric physical therapist, 20 years of experience. You work in the largest medical complex in the world. Tell us some more.
Yeah, so I've been here for 23 years at Texas Children's, and we've added a maternal health hospital, which is OB, labor and delivery, and some gen follow-up. We have fortunately been able to hire a whole team of therapists who now only work with the maternal side of things. And we do have order sets, meaning as soon as a mother has delivered her baby via C-section, they get automatic PT orders. I will say when we started going through that education for maternal care, it did open my eyes as to all these years working in the NICU. I just assumed that it was like every other post-op abdominal surgery, you get log rolling, you get your binder, you get the cursory scar tissue and lymphedema education, and then you're sent home after 3 days. That was eye-opening to find out how many of these moms were getting zero services, zero. So on the one hand, we had therapists that were actually going in to the bedside with the moms and helping them. But then there was this whole other level of education that I was trying to promote within the NICU team to the therapist to say, you need to ask the mother X. How is she doing? How's her scar? Does she have any decreased sensation still? And then refer them back out to our outpatient women's health team. I mean, I would say even still therapists have a hard time sort of asking those questions because we're very divided medical care model, right? So in the NICU, if we see a mother is struggling mentally or emotionally with everything that has happened, it's hard then to ask the attending of the baby, hey, can you help me get this mom some help? That's not my patient. But we aren't interacting with her OB or her, whoever's her midwife or whatever. So then it's hard to say, it's a little awkward to say to the mom, I think you're having some trouble. These are the people you need to talk to.
I do remember seeing moms in the NICU who had to have, delivered by C-section, because their baby could not survive, I think, a vaginal delivery as determined by her OB. And so she would be wheeled down in a wheelchair. The NICU is not conducive to healing after a C-section.
Nope.
And so, but yet to bond in whatever way she could with her baby, she would sit there for hours.
Right.
And so you're saying that as a pediatric therapist, if you were to bring that up to the pediatrician, not my patient, not my problem.
Right. And they very much, and also, and I'm not trying to throw any blame anywhere. I'm just saying these are the realities of our situation because that bedside nurse, that NICU bedside nurse, she also has no idea. How do I help this mom transfer? What do I need to help her hold on to? Where do I put all her lines? If she's got drains or anything, where do I situate all that before she can sit in a chair that's a little more comfortable than just, a transport wheelchair from the hospital. So it's not set up for a mom. So if she's uncomfortable, if she's hurting, if she, feels awkward, like she's just sitting here half exposed in a hospital gown, she's not going to pay attention to anything we're saying. And how uncomfortable is she going to be holding her kid who may have, lines and, an ET tube and all this and that. And it's shocking to see your small little baby with all this stuff, Also for that mom is that, especially if they were on bed rest with any tocolytics, now you've already had a struggle to keep your baby viable. You've maybe been in the hospital on bed rest for however many weeks, so you don't have that normal routine of being at home. You haven't done all those things that a parent would do in preparation for their baby coming home, like the rooms and all that fun stuff. So you miss out on all that. But then we know that when you're on those tocolytics for a prolonged period of time, your endurance just goes way down. And the tocolytic plus the bed rest, right? So now we have the two things. And now we're asking you to stay upright in this uncomfortable chair with your C-section. You may or may not have a binder. You may or may not have great pain control. You're exhausted because you haven't done any kind of upright activity in how many weeks. And then you add this extra stressor, you know? So I think that awareness for the NICU staff, it needs to be brought to the forefront, because then, you know, oh, she's kind of disengaged from her baby, or she seems to have a hard time attaching to the baby. Those are the comments you hear at the bedside in the NICU. That may not be it. She may want to, she can't. She's exhausted, can barely put a coherent thought together. Now you want her to do all these cares. That's a lot.
And so that's 11 weeks in the hospital where you're not walking, you're not doing all the things that we say, weight bearing activities,
Right.
like exercises, primarily in your hospital room,
Right.
trying to keep your baby in. And you're saying tocolytic therapy or tocolytics are adding to that fatigue on the other end.
Yeah, because it deconditions all of your muscles, right? Because it basically, what's the point of a tocolytic is to stop a muscle contraction. So it's not selective to just to uterine muscles, right? So that's why these moms tend to be, the longer you're on tocolytics, the more endurance challenges those women have. For those therapists that are working in the NICU, is to take a intro to OB course, just so you can understand what happened before your patient showed up to you and what might be some of the long-term consequences for that family once this baby goes home. Because what if that mom has 4 other kids?
That's a good point. What if that mom has 4 other kids and you're saying because of tocolytic therapy, all her muscles are affected, not just the uterine contractions that we're trying to stop. She's wiped out and she might have several children at home that at this point, if the pediatric therapist is kind of the last point of care individual before she's discharged, because of red tape or whatever, they're not even asking, what's your environment like? Do you have stairs at home?
Yeah.
Do you have other kids at home? Like up until this point, OB has stabilized the mom, so they're ready to sign off. OB nurse has pretty much, gotten all the meds that the mom might need, made sure she's stable. She's been in the NICU most of the time, making sure her baby is okay, plans to come back to the hospital often to visit, her baby if the baby is going to be in the NICU. But yet no one has done this round robin and circled back and said, is the mom okay?
Right. And we're very fortunate in that we have an in-house maternal health or women's health team. So I know in some NICUs or children's hospitals that might not be an option, but you can partner with area women's health PTs. We're very fortunate that we have an in-house team. So it's easy for us to convince the moms, okay, well, you're already coming up to see your baby. You can take an hour, go get yourself taken care of, so that you're better able to take care of your baby. We're very fortunate in that. And we're also very fortunate in that the OBs and the midwives, because they've been working with this group of therapists, the adult therapists, for a long time now, they're willing to write those prescriptions. So it might, be a little bit of education on the NICU therapist part to that mom to say, or I'm saying that mom, but to that other partner, because sometimes the birth mom is unable to come to the hospital because she's just incapacitated. So then you have to educate that partner that's coming in to say, how is the birth mom doing? Do you need help? Do you need these things? If not, let me find a social worker. Let me find X.
Because of just disjointed care, right? Where we have a whole team dedicated for the baby, we have a whole team dedicated for the mom. It's very rare for the two to talk to each other.
100%.
And a lot of times people don't know what they don't know.
Right.
Right. They don't even know that someone could possibly come to their home if they are chronically fatigued from being on tocolytic therapy during a high risk pregnancy. And now they have no energy to care for their children at home or this new newborn, even to go back to the NICU from their home on a daily basis. They just don't have that support and they don't know who to ask for. Pelvic health therapists are still, kind of following OB guidelines to wait 6 weeks until you see someone. Anjali, you and I both know in that 6-week period, the mom could end up back in the hospital.
Correct. And I think there's literature out there to support that the United States has one of the highest mortality rates, unfortunately, for post-delivery because I think our care is so disjointed, like you said. I think a lot of things fall through the cracks. And I think all of us have to do a better job at educating ourselves. You may not know all the information, you might not go into it in depth, but you have it in the back of your mind like, okay, well, she was on tocolytics for a week. That's why she looks like this. But then you have this other mom who got put on bed rest at week 14 and now her babies came at week 32 and she's been on bed rest this whole time. And she walks in here, two different house slippers, her gown's inside out, whatever. There's a reason she looks like that. I was like, these poor moms, I have completely just ignored your entire body and well-being for the sake of this beautiful little creature here.
Mhm.
Um,
Because
but
you've been trained to treat that beautiful little creature and kind
yeah,
of, you know that there's a team that's responsible for the mom. So you think they're doing their job and you're doing yours.
I didn't know, the body mechanics should be different for a mom with an acute C-section to lift the baby out of the bed or to even, hold a baby. Even if we pass the baby to you, what do we need to do to support your abdomen, to support your incision? Again, like if you've been on any kind of medication or anything that would increase that fatigue factor. And then also, did this mother have diabetes or anything? Because there was a big link between gestational diabetes and postpartum depression. So we don't always, if the baby comes from another hospital, we don't have access to that mom's chart. We just say it just says gestational or infant of a diabetic mother. Okay, well then it's on me to ask, was this gestational diabetes? Do you have type 2? Do you have type 1? Like what type of diabetes do you have? And then to keep an eye out, okay, well, you had gestational diabetes, so let me think about looking at some potential warning signs that you need some help. Or, hey, how's your crib set up at home? Maybe we need to look at something different because maybe it wasn't just a routine C-section. Maybe they went in there and did some extensive repair and it's going to take longer than the 6 weeks. So that's where it would be fantastic to have home health PT for the mother to go in. PT or OT, I mean, I'm just saying PT, but don't mean to exclude our OT friends, for those home mods. Like do all therapists know that showering is one of the most energy consuming ADLs we can perform on a daily basis? Probably not. But then are we asking the mom, how is your shower set up? Or do you have a bath chair? Do you have a shower chair? Whatever. And to explain to them that maybe you should take your shower at night so you can sleep for 8 hours and rest up and you're fresh in the morning, even if your routine is to take your shower in the morning. Little things like that. But I have that in our skill set or our repertoire to do. But I do think that we need some education on what are those movement patterns or movement strategies we should use with mothers who've had C-sections or whatever extensive repair they've had. Or maybe it was a vag delivery that's like a, grade 4 tear.
Grade 4 tear, yeah, no, or significant surgery to stop bleeding, placenta retention. So what you're describing is basically you are not telling pediatric therapists become OB therapists. You are just saying obtain the education, expand your network so that you know how to route the things that you're seeing earlier because you might be the last point of contact before that person leaves the hospital. You might be the last chance that they have of getting that all-inclusive care that we would want for everyone.
Right. Because really, when you think about it, a mother goes back for a well check at 6 weeks, right? So in those 6 weeks, she's been coming to the NICU. So what are we seeing? Are you seeing her gait pattern not improving?
Mhm.
Right. So immediately afterwards, she's going to have that antalgic sort of, I'm still pregnant gait. Okay. That should start to improve. But if you still see that gait pattern 3 weeks later, we have an obligation to say, I feel like, what can I help you with? Where are you hurting? What's going on? Are you getting PT? Are you getting OT? No? Okay, well, let me give you some stuff to tell your OB or tell your PCP that you need help with. So again, I'm not asking women's health therapists to become NICU PTs. I'm
Sure.
not asking NICU PTs to become pelvic floor therapist.
Mm-hmm.
But what I am saying is that we all have, our basis is all movement, right? So even if that isn't your subset or specialty, you still know what normal gait looks like. You still know what normal movement looks like.
Mm-hmm. And again, you said the basis of what we do is movement. And, that's where I call in occupational therapists because, they do offer that mental health component, to
Mhm.
care.
Mhm.
You sent something across my desk a few weeks ago that just blew my mind. I didn't realize that suicide surpassed cardiovascular um, events in the leading cause of death in the postpartum period.
Isn't that tragic? You did all this work for 10 months for this little human.
Yeah.
And because we're so fragmented as a care model, we don't pick up on that. It doesn't get picked up on. I mean, I will say, I'm acting like it's just tragic, but pediatricians do the Edinburgh scale with all parents or all newborn moms of newborns. Let me rephrase.
Really?
Yeah, so it's required that they do that. I
Oh, it's
will say
wonderful.
mothers are incredibly smart about lying because when you're 25 years old, you're incontinent. You've never had that before in your life. All your girlfriends are going to lunch at whatever, and you're like, I can't go anywhere. My baby won't sleep or eat because they've got raging reflux. I've had this C-section. My body image is completely shattered now. But I'm going to tell this pediatrician I'm fine. At my 2-week check, at my 4-week check, at my 6-week, I'm going to tell that OB that I'm fine.
Yeah.
So because mental health is unfortunately a giant stigma here, right?
Mm-hmm.
So it's hard. I mean, no 25-year-old wants to admit she's depressed and doesn't want to get out of the house.
How common is disordered eating?
Correct.
To get your body back.
Get your body back. I mean, my word, it's not going to be the same, but
we don't normalize that. We
right,
normalize, you know, not looking like you're still pregnant at 6 weeks.
right. And everybody recovers differently. Everybody's prenatal course is different. You could have 3 babies and every single recovery is going to be totally different. Every single pregnancy is going to be totally different. Just because they're your babies, that doesn't mean anything.
Yeah. What would you want pediatric therapists to know about OB care? What are the top things?
I think one big thing would be to look at the history, right? The pregnancy history. Not to say she was on bed rest starting at week 16. What were the interventions during bed rest? Were there any fetal transfusions? Was there increasing use of tocolytics? Did like they tried the cerclage first and then they did this? Like what? Because those things are going to impact your baby's mother's behavior, right? Or her ability to do cares or her ability to engage. So don't just write that mom off as, oh, well, she's just more interested in her phone. Maybe that is all she can do. This is her only salvation because everything has been a train wreck. So not to say that there aren't moms that are disengaged. I'm not discounting that, but we should be able to decipher, is this a disengaged parent because that's her personality? Or is this a disengaged parent because of all the stuff that has just happened to her in the last, however many months? And now her baby is super sick. Or even the fact that every C-section patient should have a binder. Even as simple as saying, hey, Miss blah, 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 do you have your binder on today? Is it still fitting you properly? Because that in and of itself is huge for respiratory drive, pelvic floor control, all of that.
Wow. Yeah.
We didn't even talk about all the work that has to go into pumping and breastfeeding and all that on top of all those other issues you had. But that's a whole nother level of, stress for that mom.
Sure.
I think if I could say anything is that just to all the therapists out there, just, step out of your comfort zone and take an intro class to something. Even if you're an adult therapist and there are lots of basic NICU courses that don't talk about necessarily the impact on the mom, but just so that you have an idea of what that mom is going to walk into. Or just go visit your NICU. Just grab your PT partner and say, hey, I want to come see what you do all day. We're happy to show you.
Wow.
So, but
Awesome.
I think that's how we'll start to close this gap. I hope.
Awesome. Thank you so much.